which actually says that, see, we surveyed these individuals from round one, and in round two, we could not follow up on this individual. So they provide like the individuals that were not followed up on round two, why they could not be followed up? Were they due to mortality? Were they because they migrated to another place? So we used the mortality information from there, merged it with the information of round one, and then performed this analysis. So as for the sampling strategy of ISTs, they employ a stratified sampling design, and they covered all states and union territories of India except Andaman and Nicobar and Lakshadweep Islands. Further details are available from the user guides. So the final sample size of the study is basically 1,664 older adults across communities, across families who are nested within communities. So these are the study variables. So basically, in large, we have included the outcome variables, old age mortality, and we have included person level, family level, and community level covariates. So when go to the statistical analysis, what we have done is that first we see like what is the actual incidence of old age mortality in India between the period from 2005 and 12, and then we also group it by gender and ages. Then the one thing that you need to also take into account is the data, the tracking sheet data, since there are observations lost to follow up. So that becomes a censored observation case. So we use survival analysis techniques here. So for bivariate analysis, we performed log rank test, and for multivariable analysis, we estimated a multi-level Weibull proportional hazard model. So why Weibull model? We'll be discussing in the next part. But the other thing is that in the we have three levels in the Weibull model. The first level is the individual itself, then there is family, and then there is community. And then we examine the heterogeneity in mortality risks, and also we estimate the sensitivity of these estimates to unobserved variable bias using the e-value method. So now I quickly move to the findings, and this, as you can see, between 2005 and 12, almost like 39 older adults experience mortality out of every 1,000 person lived. And the estimates are also there by male, by gender, and by age in years. So a common trend that you can see is that the mortality at the higher ages are high, which is expected. And here also see the mortality among the male population, there's a gender bias, but the male population is higher. And it is well established also that females or female older adults tend to have an advantage in terms of mortality during the older ages. So now this is basically the survival curve of old age mortality. One thing that you need to observe is that you see the jump in hazard of mortality increases over the years. And this is the parametrics model assumption, the parametric model estimates of the five statistical models that were used to calculate old age mortality. So in here, you see the archaic information criteria and the Bayesian information criteria values are lower for the Weibull model. And the lower the values, the lower that model is a better fit to estimate old age mortality. So that is why we use Weibull model. And one more thing to keep in mind is that the Weibull model is used in cases where the hazard is not equally increasing or decreasing. So as we have seen from the previous graph that the hazard was increasing with time. So that's why we have used the Weibull model. So now we quickly move to the heterogeneity estimates here. So first, I've shown the median hazard ratio, but the median hazard ratio is a abstract number basically, which gives us the median value of all possible estimation of pairs of older adults and their mortality risks. So as we can see that in the community level, the median hazard ratio is much lower than the median hazard ratio at the family level. So from here, we can conclude or we can say that the heterogeneity in mortality risks is actually higher at the family level compared to the community level. And when we talk about the ICC or the intra-class correlation coefficient, there also we observe the similar trend. So what the ICC does is the MHR talks about heterogeneity or inequality in risks. The ICC talks about correlation of mortality risks among older adults belong to the same group. So as you can see, the correlation among older adults belonging to the family level is also higher than older adults belonging to the community level. So after this, after estimating the Weibull hazard model, basically, we also see the difference in the hazard of mortality risks by different risk factors across the time period. So these are some prominent risk factors that we observe that like individuals who smoke tobacco actually had a higher hazard of mortality, and also individuals having lower education those who belong to the nuclear family structure. Those who belong to the nuclear family structure and those who belong to disadvantaged social groups or the lowest wealth quintile or the lowest economic quintile also had higher hazard rates. Okay, so basically from this analysis we observed what we observed is that the prominent individual level risk factors are basically employment, the partner support, social participation, and also the health factors. Like we observed whether the participants have chronic diseases, and if they are found to have a higher risk of old age mortality that we observed among the individual level. And when we talk about the family level, as I've already shown, the family level mortality varies, and also family level factors like their income level, poverty status, the social group that they belong to actually affect the lifespan of older adults. And the one thing to note is that in the higher income countries, where old age mortality has not been shown to have an economic gradient. But in the case of India, as the case is, actually older adults belonging to the lower rung of society have a high economic gradient. This may be due to the prevalence of universal healthcare schemes in those countries, which is absent in India. And so the crucial policy information that we get from these countries, from this analysis, is that we give adjusted estimates, which are adjusted by the unequal risks, and we give the risk factors across level. And one more thing, that we have also tested these estimates for sensitivity to unobserved variable bias, and the unobserved variable bias sensitivity was minimum. So these are robust estimates, and since family level heterogeneity have been pointed to, so policy interventions at the family level are required, and we have to undertake further research using more recent data to formulate crucial policy changes for these recent years, because IHDS datasets are a decade old now. So that's all for this presentation, and you can contact me for further questions. Thank you.
Thank you so much, Ronak. It was a very interesting presentation on the clustering, especially the old age mortality and different socioeconomic factors taken into account. With the interest in time, we move on to the next presentation. It is from Dr. Rashmi, who would be speaking on onset of chronic diseases across varying birth cohorts, unraveling the health and longevity of Indian adults. So, Rashmi, you can maybe present your screen and yeah, take over.
Yeah, is it audible?
Yes, you're audible.
Yeah, the
If you can
screen
go to
is,
the
yeah,
presentation mode. Yeah, you're in
yeah,
presentation mode. Please start.
okay,
Thank you.
okay. Good evening, one and all present here. My name is Rashmi. I am a PhD scholar from International Institute for Population Sciences, Mumbai. Today, I am going to present my work on the topic onset of chronic diseases across varying birth cohorts of Indian adults. So, basically, before moving on to understand the concept of development or the onset of chronic diseases, I think it would be better to highlight the roller coaster scenario of the longevity scenario across the globe and the India. So basically the longevity which has increases across the globe in the last few decades due to the decreasing mortality and advancement in the medical technologies. These has result into the decrease in the communicable diseases across the globe, and in India it has been seen that the communicable diseases has significantly decreases from 61% in 1990 to 3% in 2016. However, correspondingly, there was an increase in the years lost due to chronic diseases from 30% in 1990 to 55% in 2016. These scenarios give a broad picture showing that the extended life gained in the longevity was suffered by morbidity during the last few decades. This term has been referred as morbidity expansion. Morbidity expansion is basically the state in which the individuals would live longer but spend these additional years in the worse health. Today, this theory is best fitted in many developing nations like India, where the population aging had fueled the chronic diseases. So, is single morbidity expansion only the threat? The statistics shows that the burden of chronic diseases is increasing in the adult population. According to WHO report, it shows that 15 million deaths among working age adults due to chronic diseases had occurred, and among whom 85% were from the low and middle income countries. Chronic disease burden had occurred in every age group population, which significantly challenges the best fit morbidity theory, which is the single expansion theory across the globe. So, this scenario has also been highly evident in India because of its vast demographic and epidemiological shift. So the question arises, is India experiencing a single morbidity expansion where the additional years added in life are suffered by diseases, or are the diseases expanded in early ages too? What is the scenario across different cohorts or the generations? Here comes the need of the study, where we want to understand whether the younger generation is under the chronic disease havoc, and to understand how much time does the Indian adults spend in a chronic condition. These questions can't be answered showing the chronic disease prevalence. However, we need to explore the first age at which the Indian adults are contracting the chronic diseases. This comes to the objective of our study, which has explored that the age at onset of chronic diseases across varying birth cohorts of middle-aged and older adults in India, and their prognostic factors using the competing risk setup. The data used to explore the objective is from LASI data using 65,258 individuals aged 18 plus. We have used kernel density plot, box and whisker plot to explore the age of onset of different chronic diseases across the varying birth cohorts, and further, the competing risk analysis, a form of a multi-state survival model, has been used to understand the prognostic factors contributing towards the onset of these diseases. The kernel density plot and the box whisker plot, which explain the onset, will be shown in the results. I would also like to point out here why we are using the competing risk model. Why not the general hazard survival model? So basically, the competing risk analysis here tries to cover when the time to event analysis, sometimes when the other events may preclude the time of occurrence of the primary event of interest. At such events, the competing risk setup is very helpful. For example, in this setup, when we are trying to conquer what is the risk of hypertension, there might be the situation when hypertension may or may not be affected by other diseases like diabetes and all. So using the competing risk setup, we are trying to solely understand the risk of hypertension, keeping in control the risk of the other diseases in the analysis. So further moving on towards the variables which were considered. Here, the outcome variable is the age of onset of 7 medically diagnosed self-reported chronic diseases, namely hypertension, diabetes, lung disease, heart disease or stroke, arthritis, neurological disease, and cancer. The main explanatory variable here is the birth cohort of the individual, which are born before 1951, 1951 to 1960, 1961 to 1970, 1971 and above. The control variables are also considered in the analysis, which are the individual, behavioral, and socio-demographical variables. So moving on to the results of the study, here it shows the scenario of chronic diseases in Indian adults. See, the results highlighted that the age 6 adjusted prevalence of having any chronic disease is around 41.7% across the Indian population. Hypertension is significantly affecting the population with a higher percentage of 26.8%, followed by diabetes, arthritis, lung disease, heart disease and stroke, and neurological diseases. Further, moving on to see whether the age of onset of diseases is more highly precedent towards the younger generation or the older generation. So here it shows that the chronic diseases are expanding in the early ages of the younger generation. The age of onset of the chronic diseases, you can see here the peak here or the concentration of the chronic diseases at the early ages of the younger generation, 1971 to above a birth cohort, and it has precedently decreases throughout when we move towards our back generations. Next, we have shown the box and whisker plot, which shows that nearly half of the population develops chronic diseases nearly at the age of 40 to 50 in the younger cohort. In comparison to those who were born in 1951, the median age at onset of diseases were around 65 to 70. But in the recent generation, in the recent cohort, we see that in the 1961 to 70 birth cohort or the 1970 plus birth cohort, this median age at onset has decreases to 48 to around 40 age. So further seeing the results of the prognostic factors, which has been the factors which are affected the onset of the chronic diseases using the competing risk setup, it shows that significantly the younger cohort have been in the higher risk of having any type of chronic diseases, especially the hypertension and neurological diseases. The risk of developing hypertension, arthritis, and cancer was higher among the females than the males. Further, we have seen that with the increasing level of education, the risk of the hypertension and diabetes has also increased in our population. The working status, in terms of working status, those who were not working, the risk of having a particular, of obtaining a particular disease was also a little bit higher than those who were currently working or have ever worked but not working currently. Significantly, the depression has significantly affected the risk of nearly all kind of chronic diseases, especially the neurological diseases among the middle-aged and older adults of India. Here we can see that those individuals or those adults who were involved in physical activity, in higher physical activity. I should like to mention here that the physical activity here is derived from both the moderate and the vigorous physical activity. So it also includes the vigorous physical activity variable here. So those individuals who were involved in physical activity had a higher risk of developing heart disease or stroke. Further, we see that compared to the poorest 10th quintile households, the hazard risk for hypertension, diabetes, lung disease, heart disease or stroke, and cancer were highest among the adults and elderly in the richest wealth quintile households. Adults in the urban areas were less likely to develop arthritis than their rural counterparts. So concluding towards the different findings which we have found here and towards the conclusion, the present study highlights that the chronic diseases are emerging earlier among the independent and working age group population. Younger adults are no longer healthier than their predecessors, and lower median age at onset of chronic diseases in the younger cohort shows that the younger adults are spending much more time in the chronic conditions. This highlights towards the fact that not only the single expansion, morbidity expansion, but the India is now on the verge of experiencing the double expansion of chronic of morbidity expansion theory. Further, the education and the working status, depression, physical activity, household wealth quintile, and place of residence emerge as the prominent prognostic factors predicting the onset of chronic diseases in the middle-aged and older adults in India. The early onset of chronic diseases in the independent and the working age population can have many social and economic implications. For instance, it can create a greater healthcare burden when these individuals who are today contracting the disease at an early age, when they grow older with these diseases, how much burden it can create on the healthcare system and the overall health system of a country. So the proper interventions and policies are required to tackle such situations in the future. The recommendations are we literally need to reinforce the balance between the physical and the mental life of individuals, as both the hypertension, diabetes, along with the neurological diseases are on the verge of increasing their threat towards the younger generation. Looking at the sedentary lives of the younger generation, and in accordance to the findings of this present study, the programs are required to promote the habitual physical activity across India. More research on adults and the elderly is required to point out the need for health data and the policies towards a healthy and a better nation's future. Thank you.
Thank you so much for Dr. Rashmi. It was very interesting to know about different metabolic disorders and how we don't want to age earlier with a lot more diseases, I think. With the interest of time, we go to the next speaker, Dr. Varun Dwarka. Varun Dwarka is a bioinformatician. He's an expert in aging and longevity research. He focuses a lot on genetic and molecular aspects of aging. He has extensive experience in this area. So he's speaking about the potential biomarkers of longevity. I let Dr. Varun take over.
Thank you, everyone. And to the organizers of Longevity Asia, thank you so much for this invitation. So my name is Varun Dwarka, and I serve as the Director of Bioinformatics and am a Principal Investigator at True Diagnostic, which is based in the United States in the state of Kentucky. And so I'm actually going to go a little bit different here, because while I was thinking about going through all of the potential biomarkers, I'm actually going to be thinking a little bit more on the application, and especially how we as a company are taking the science to the consumer and the researchers. And so the title of my talk will be using AI and ML to develop the most predictive and clinically informative epigenetic measures. And so to introduce me, I have to introduce the organization that I represent. So True Diagnostic, our vision is just to provide the best aging and clinical medicine insights via epigenetic methylation, while collecting extensive covariate data and forming the largest phenotypic, multi-omic, and epigenetic database platform in the world. We've been around for only 3 years, and in that time, we have our own lab, so we are pumping out a lot of DNA methylation data. We have actually 13 countries of distribution, and one country that is near and dear to my heart is my motherland of India. And so that is one of the places that I'm trying to really tackle. We've been able to publish 20 or more papers in the short 3 years that we've been around, and have filed about 10 patents, and have multiple collaborators all across the world. And so why do we do this? It's because the main reason is to collect the data, and this data is what facilitates the research that we do, and specifically this research that my lab does. And so even though it says 100,000 patients, this is actually a more culmination of 50,000. And we actually have longitudinal data. So the reason why all this is important is because of the metadata that we collect. This includes variables such as cancer diagnosis, Alzheimer's, depression, HIV, even lifestyle ideas where it comes from alcohol consumption and all that. The reason why all of this is important is because we are using this metadata as a way to train different AI and ML models using DNA methylation as the baseline. And it's through this that we've actually been able to commit in a large amount of resources towards the research. And so this really, a lot of our work has actually been published in Nature Aging, Genome Medicine Frontiers in Nutrition, and Aging itself. And so while I will go through a lot of slides, and especially in the context of summarizing the application, please contact me if you want the direct publications. And so to kind of start, I'm going to start with a short background. What is the science that facilitates all of this research and the IP that we develop? To do this, we have to understand the central dogma of molecular biology, where we have to understand how the DNA is organized in chromosomes and the relationship it has to epigenetics, not the genetics, but the relation to epigenetics. If you're familiar with epigenetics, there are multiple types. There's chromatin modifications or histone modifications. There's DNA methylation and non-coding RNAs, where these RNAs that don't actually code for messenger RNA are able to come back and actually regulate the gene expression. But the biomarker that I will be focusing on is DNA methylation, where these are methyl groups added to the cytosine or the Cs of the DNA, which then are there to, well, popular school of thought is that the addition of that DNA methylation is able to hinder gene expression. And as you remove those methylation groups, then you can start to express the gene. And this is also dependent on the location. Typically, the understanding is that it happens in really functional areas, such as the promoter region. And so using DNA methylation, the reason why we focused on this as a biomarker is understanding the effect of the epigenome based on the environment. So based on nutrition, stress, toxicants, pathogens, and other environmental cues, that tends to affect the epigenome, which then is in part regulating the genes. Now, if you compare this to other tests such as that maybe use the genome, so like genomic or genetic tests, you have to understand the difference here. When you do a genetic test, and I'll label 23andMe, I'm not saying anything bad about them, is that a genetic test is very important because you take one test and you understand what your predispositions are. But the problem here is that with age, you can understand a predisposition, but age is not a static thing. It's a continuously changing alternative. And so with a genetic test, while it is important to understand predispositions, that genetic information hopefully is unchanging. You're not seeing major changes in your genome. And there are also few interventions to change genetic risk. Of course, we have things like CRISPR-Cas9 that are really becoming science fiction and really being starting to implement. But CRISPR is not anywhere close to being used on especially adult humans. And so really understanding how the regulation of that genetics is very important. And this is where epigenetic testing is really going to be coming into play. The idea here is that patients can retest and manage progress several times across the lifespan. There are many interventions that actually affect epigenetic risks or changing epigenetic risks, specifically by hitting DNA methylation. And while some of those signals are inherited, especially when you think about certain genomic regions, majority of your DNA can actually be changed based on just environmental cues and also lifestyle changes. And that's where we are existing as a company. And so what can you calculate? So using DNA methylation, what are the aspects that you can look at? You can actually look at methylation QTL variants. And so this is really looking at the results and differences in DNA methylation across individuals associated with polymorphisms. You can calculate age, biological age, which is what I'm going to be focusing on today at some probes, which are altered throughout the life course. So it's not your entire DNA, it's more specific locations. You can look at cell type specificity. You can deconvolute from whole blood individual cell types. You can look at exposures. So using DNA methylation, what is your exposure rate to different for alcohol, for smoking, and other exposure rates, including pollution. And one of the most important things is it's outcome associated. DNA methylation can be causal or consequential to disease states, which makes it a great biomarker to look at association to disease. And so how do we turn this into a test? So what we do as a company and is following very much the research route. So what we do is that we send a kit out. Individuals are able to extract their blood, send it back to our lab. In our lab, we were able to extract the DNA, undergo bisulfite conversion, and then use the Illumina EPIC 850K array. This is a research tool that I'm sure many of you are familiar with. If you are not, please email me. We can talk a little bit further. But the idea is that by using the 850K EPIC V2, which is looking at about 900,000 CPGs at a single time, we can actually estimate the probability of methylation at individual CPG sites. Now, this is where the fun starts, and this is where really my team is kind of coming into play, is that by using these CPGs, we can train it to different outcomes. So whether it be chronological age, disease probability, or any other type of output, we can identify which CPGs are highly predictive of that outcome. And it is under this guise that we are able to build AI and ML models so that once we build the model that is highly predictive of that outcome, we can then reverse engineer it anytime that we get a new sample. So for example, here, even something so simple as, does this person have COPD, yes or no, or 1 or 0, we can create a classifier that way. And so with that said, I'm going to introduce the main use case. And this first section is going to be a little bit longer, but it's going to go through at least one of the clocks that we have developed. So the concept here is really understanding the difference between biological age and chronological age. And why are we focusing on aging? Well, if you think about it, the progression of aging is really the significant driver for disease risk. A lot of diseases are driven by the fact that you are aging at a higher rate. But the problem is this: people think that the older you are chronologically is the reason why you are getting more disease risk. While that is somewhat true, there are individuals that, let's say at the age of 45, if you are taking care of yourself, your biological age or the age of your organ systems, your cells, may actually be lower than your chronological age, which is likely because you're not imparting a lot of aging effects onto yourself. And so really understanding this biological age becomes a better determinant of your overall success as a human being and in the aging realm. And so really quantifying biological age is going to be very, very helpful. And epigenetics seems to do a very good job. So if let's say you calculate biological age using these epigenetic markers, let's say you are higher in your biological age than your chronological age. What we know, and this review here is actually a very good review that really looks at it, is that your all-cause mortality increases, your cancer risk increases. Things like stress can cause that age to be higher up. But then if you want to get lower age deceleration, as we call it, biological age deceleration, this could be due to the fact that you're taking in healthier food, you're exercising, and you could look at supplementation, which is then decreasing this age. And so this now becomes an internal tracker, very similar to an Apple Watch, but now this is a molecular tracker. And so how we've developed our first clock, if you will, we call these epigenetic clocks, is that we wanted to look not only at epigenetics, but incorporate different layers of aging biology. So molecular biology is not just one thing, it's multiple things. You have your epigenetics, your genetics, you have your transcriptomics or your transcriptional gene expression, and you have metabolites. And so that's what we did. In collaboration with Harvard Medical School and Mass General, we actually created a data set of individuals from the Harvard Medical School database through Mass General, and essentially looked at methylation using the 850K array across 5,000 individuals. Of those 5,000, 1,500 we did proteomics using the SEER platform. We extracted their clinical data through EMR, and also their metabolite information was collected using Metabolon, the metabolite platform. So in order to do this, what we actually did was we developed our own internal EMR age. This is an age that is based on EMR data. And the way that we trained it was that looking at 61 different clinical phenotypes across 60,000 samples, we actually used a Cox regression model to identify which of these 61 were highly predictive of time till death. This is the time that of all those individuals of when they passed away. And then using this information, we predicted which of these would actually be very good at predicting somebody's time till death. And so we actually created our first model using EMR age. But the problem with this is that you don't actually, like for an average consumer, getting their EMR data is very, very hard. And so as a company, we do a lot of DNA methylation. So how do we convert this to something that is more usable for us? And that is where we actually trained everything to DNA methylation. But the cool thing here is that you can also not only train DNA methylation to age, we can actually use DNA methylation to estimate different protein levels, different clinical levels, and different metabolite levels as well. And remember, we collected all of this matched to methylation. And so what we did was we created about 396 models where each individual model is able to predict a protein, a clinical value, or metabolites. And what we did was we used lasso penalized regression, where we essentially just identified which CPGs are able to accurately and predictively predict the protein, clinical, and metabolites. So we actually created all of these models as well. And last but not least, we put it all together. Now we created this EMR age. This is an age measure based on EMR data. And now we trained all the methylation data, all the estimates from methylation for the proteins, clinical, and metabolites. And notice, we also created in a different paper, a 12-cell immunity convolution, meaning from whole blood without using FACS sorting or any kind of cell sorting, we can estimate the relative percentage of these 12 immune cells. And all of this was combined and trained against EMR age to create this value called omic MH. Now, this is all fantastic from a methodology perspective, but how does it work? Because in the end of the day, we care about the people that are using this. And what we see is that this measure is actually very clinically relevant. What you're seeing here are the prevalent cases and incident cases. And what I'm doing is comparing all of these to previous epigenetic clocks. We're not the first company to create this, or sorry, we're not the first research group to create this, but we wanted to benchmark this against existing clocks. And what we see is that what we created outperforms every other epigenetic clock that is out there in the context of associating to disease. So for example, all-cause mortality, what you're seeing here are the hazard ratios. The more right they are, the more relationship there is to that value to that disease. So all-cause mortality, type 2 diabetes, stroke, depression, COPD, and cancer, meaning as the omic MH is higher, that the estimation or the association to that disease is stronger as well. But what's more important is the 5-year survival and 10-year survival. So what we did was we predicted whether an individual that has a higher, let's say a higher value, omic age value, does that predict whether that individual will survive or not in 5 or 10 years? And what we see is that the AUC, or the percentage of predictiveness, or essentially a value to show how predictive that measure is quite high. It's at 0.894 or 0.889. A value of 1 means perfect prediction. But when you compare it to, let's say, chronological age, this is your chronological age, you could see that it's more predictive than just looking at their date of birth or any of these existing epigenetic clocks. And so with this, we're very excited because we seemingly created a measure that was highly clinically relevant and is able to predict survival and other diseases. And so the next question is, how do you take this to the consumer? And so what we do is we actually created a report where we could tell you your omic M age or your epigenetic age compared to your calendar age. And because of all of these models or these associations, we could predict the risk of disease, such as mortality, COPD, cancer, depression, again, using the same type of modeling that's come from here. And then also what's really important is comparing it to the rest of our data set. We've done this for 50,000 patients. So now that individual can use that measure and compare against the rest of the population. I will say, because this is an American company, a lot of our users are majority from America, but what we're trying to do, and this is a huge part, is to kind of bring it to the Indian subcontinent. And that's actually been a passion of mine here as well. But what's important is that not only can we give you a overall score, but remember, we have models to also estimate individual proteins, those metabolites, and those clinical values without actually doing additional blood work. And so that's also additional insight that we could provide to the consumer just based on using those individual metrics that go into the overall multi-omic clock. And if you have any questions, please let me know. We can email after the presentation if you want to know more about that. Now, that is one flavor of the clock. We actually have other flavors. I will go through these slides a little bit more quickly. However, I want to make sure that I touch on how these use cases can be also used in different settings. We also have organ system specific clocks, meaning, so this paper came out from Morgan Levine's lab at Yale University, and we work closely with the lead author, Raghav Sehgal. And what we've actually been able to do is license systems age, which is essentially using blood as a surrogate. You can estimate age from other tissue types. And the reason why this works is if you think about it, blood is a circulatory tissue and is able to go through all of these different organ systems. And so therefore it's capturing different methylation states from these individual organ systems as well. And so using that kind of philosophy, we were able to train a lot of these using blood as a surrogate, using blood in the matched organ, be able to understand which of the CPGs are able to capture the aging process using different age-related biomarkers from individual organs, and then turn that or deconvolute that into blood. And so now what we can do is by taking blood, we can estimate those aging biomarkers and give a aging score or an age for individual tissues, or sorry, individual organs. And so how we do this for the consumer is that what we can now tell you is not only look at overall age, your like overall symphony age, we can then deconstruct it based on, okay, you're 45 now, but based on those lung biomarkers, you're 38, 44, 40, and then 49, 42, based on individual organ systems. So you're taking an overall score and now decomposing it to something that is a little bit more manageable for the consumer to understand. So let's say if this person wanted to decrease their age, it seems like their musculoskeletal age is actually the highest. So then they can work on different ways to decrease it. And that aspect is something that we're still working on at True Diagnostic with our clinical team. But last but not least, we also look at the overall pace of aging clock. If you are familiar with this space, you will know this paper by Daniel Belsky, who again is another collaborator of ours from from Columbia University, and Terry Moffat from Duke University. But the idea is this: all of the other clocks are showing an amalgamation or a combination of your current and past health. But for somebody, let's say, that's recovering from, let's say, alcohol use and wants to make a change in their current life, they need an estimate that is more proper for now, because they might score higher based on all the damage that they've done in the past. And so in order to maybe create a clock that is more representative of your current state, what these individuals did was that they actually used a cohort of individuals from New Zealand, from Dunedin, New Zealand, and they tracked those clinical values across a longitudinal cohort, looking at 19 different clinical values. So starting from their birth at 19 in the year 1972, all the way until more recently, 2018, they were able to use all those clinical values and create a single pace of aging score using an using a I think it was a Cox proportional model or a model of sort. But then using that pace of aging, they then transposed it to CPGs. Same way that we were able to do it for omic age, what they did was they calculated that pace of aging and then used an elastic net to identify which CPG sites are predictive of that pace of aging. So now you can use this epigenetic test to estimate that pace of aging. And what that number or that predicted number really means is it's a measure, is a value which describes the rate at which you're aging per year. So what that means is for an individual like this, who has a Dunedin pace value that is 0.89, for every year that they're aging, they're only aging at a rate of 0.89 years. And again, so this is actually a snippet of what you could what we show for our customers. And this is where it really comes into play, not only understanding what their value is, but as people are going through different life stages, different interventions, taking different supplements, they could track how they're doing. So for this individual, you know, they took the second test, things weren't going well, but then they come back down to 0.89. Now, compared to the first test, nothing has changed, but now they can realize, hey, what did I do differently in my second test versus now? And then they could use that as a way to kind of track their internal aging. What is really important, and this is where a lot of my team comes into play, is to test a lot of these measures. So even though we didn't create Dunedin pace, we really tested it. And so we actually published a paper in BMC Medicine about 2 months ago, in July 29th, where we actually saw that when you compare twins, where one twin is on a vegan diet and one twin is on an omnivore diet, the individuals who were on a vegan diet showed lower Dunedin pace values, meaning their pace of aging, their immediate pace of aging was lower. And this was done in only 8 weeks. So now we're understanding what is affecting these clocks, especially with Dunedin pace. And this is why we really like this and why we license this in or providing it to our customers. We also know that lower caloric restriction leads to lower Dunedin pace. This was done actually by Daniel Belsky's group and was published in Nature Aging. And what is really interesting is that things like PTSD and depression can also be attributed or can lead to or is associated with higher Dunedin pace. So meaning now we're not just looking at diet, but we're looking at how that individual's mental state is now affecting that pace of aging or that current aging process. And so now I hope you're starting to see how this can now become a clinically relevant tracker that is looking at current state of aging, along with the other two epigenetic clocks, which are showing more of a current and past aging process. Now, number 3, estimating age, and this is my last use case, estimating age related to disease. So why do we care about age? Age is honestly just a number to assess how much risk of disease you're going to get from a clinical perspective. So in all of these cases, the idea, or if we were to show this flow chart, we start with CpG methylation biomarkers to estimate all of these EBPs or epigenetic biomarker proxies, or in a classic clinical case, you'll estimate somebody's CRP or plasma viscosity to estimate how much of their inflammation is changing. So CRP increases, you presume that their inflammation is increasing. And if that inflammation increases, then that means that either their diabetes, cancer, or asthma can increase. But as you can see, this is kind of a problem. You have multiple areas of connection, and it's really not specific. And so we realize that. So why are we estimating age? To look at disease. So why don't we just go directly to the disease itself? And so now we're rethinking a lot of our processes, and actually instead of looking at just epigenetic age, we're also creating models where we identify CpGs that are directly estimating the risk of asthma, the risk of diabetes, and risk of cancer. And we're calling these methylation risk scores. We're not the first people to do it from a research perspective, but we are the first people that are, or the first group that we're trying to take this more to consumers, and especially in the United States, be able to get FDA approval, which we're hoping to get in the next 3 months. And why is that? Well, if you think about it, well, I mean, here are some of the initial results. As I mentioned before, AUC is a measure to look at predictiveness, and as the closer you are to 1, the higher the prediction. And as you can see, compared to a cancer specific company, which is Grail, their average AUC across their different cancers are 0.81. However, even with our own cancer, our cancer methylation risk score, we've improved it to 0.85. But that's not the only thing. The most important thing is that we're going beyond cancer. We're looking at type 2 diabetes, COPD, stroke, coronary artery disease, and most importantly, just like how we were looking at depression and PTSD, we have one for depression. And what we hope is that these tests are going to actually bring more insight into the health of individuals when it comes to things, to diseases or to disease states that have not been looked at really, or maybe in certain societies are still looked at as not important. Depression is one of them. And so using that kind of idea, we're hoping that this will make an impact, not only in society, but just overall health. So to summarize, to impact aging, we need diagnostics and treatment. Epigenetics clocks serve in this capacity. So we have been fortunate enough to contribute to a lot of these current epigenetic clocks because they are able to estimate epigenetic age, which is a surrogate of biological age. And these epigenetic ages are seemingly clinically relevant and predictive of disease and health. We can get resolution to the individual organ. So now we can understand not only overall age, but like we could look at more individual organ age, and also the current pace of aging versus overall age or historic age. These epigenetic biomarker proxies, these which I kind of went through a little bit quickly, these are the estimates or surrogates using DNA methylation of those protein, metabolite, and clinical values can provide more resolution from DNA methylation data without doing additional testing. You don't have to do proteomics. You don't have to do metabolomics. And it also allows for low cost and easy collection methods. And from the same data set which generates biological age. So now you're not only understanding the biological age, you're understanding how these metabolites, those proteins and clinical values are contributing to that biological age. And last but not least, we are developing methylation risk scores, and this is possible because instead of directly estimating age, you can now go to the exact disease and estimate age-related disease risk. And in closure, I'm just going to talk a little bit about the offerings. So I only looked at 3 of the offerings that we have, but we've used the same kind of idea or the same type of philosophy to look at skin clocks, looking at different clocks, epigenetic clocks based on repetitive regions like ERV and line 1. We have publications on all of these. We even have a P16 T cell senescence predictor as well. And for those individuals that are getting into bioinformatics but do not have coding experience, we've actually developed our own software to help with this epigenetics analysis. And so it automates EWAS, DMR, DML studies, epigenetic clock analysis. So all the clocks and algorithms are now stored in this program and is available to you if you are wanting to use EPIC v1, EPIC v2, or MSA methylation array data. And the most important thing for me is to bring these costs down so that places that are maybe not wanting to spend the incredible amount of money to be able to bring all of this technology to average consumers. And so what we've been doing is working with Illumina to create an MSA-specific algorithm. And what this is hopefully going to do is cut costs by 50%. And so areas of the world that need those cost reductions can now still have the same technology available, especially in their clinics. And with that said, thank you for your time. Please email me at varun@truediagnostic.com or link with me on LinkedIn. And yeah, happy to take questions here or on email. Thank you.
Fantastic, Dr. Varun. It was very exciting to listen to you and what you've been doing, and very exciting work coming out from what you have done, I think. So I think we will have the discussion session or Q&A by the end of the whole session. So I will let Dr. Shashanka take over because I have to leave now, but I'll join back by the Q&A session. Thank you so much, Varun.
Thank you.
Thank you, Varun. Thank you, Dr. Nikhil. As well, let me just take over. I think our next presentation is from Pushpinder Singh. He is a research scholar at Baba Saheb Bhimrao Ambedkar University. Pushpinder?
Yes, sir. Am I audible?
Yes, you are. Please continue. Take over.
Okay, sir. My PPT is visible, sir. Hello.
Yes, it is.
Okay. Good evening, everyone. My name is Pushpin Kumar Singh. I am from Baba Saheb Bhimrao Ambedkar University, Lucknow. Today, my topic is mapping anemia inequality, a regional analysis of socioeconomic factors among women of reproductive age in India. The introduction is like global health concern. Anemia is a global health concern. Disproportionately affect the women of reproductive age in low medium income countries, including India. The WHO defines the definition of anemia, that is the woman having anemia, hemoglobin less than 12, and the woman pregnant woman having the hemoglobin less than 11. Maternal health impact is a very effective in this, like significant threat to maternal well-being, increase the risk of complication and mortality, which was given by the WHO in 2024. Iron deficiency anemia is most prevalent, that is 1.62 billion globally, and it caused by the inadequate dietary intake and limited healthcare access. Multifactorial nature, anemia have a multifactorial nature influenced by the interplay of socioeconomic and biological factors. The main focus is on India because despite the initiatives like Anemia Mukt Bharat, is still the anemia rate is exceeding 50% among the women of reproductive age. Research imperative is this: the need for understanding the regional variation, explore the interplay between the multidimensional poverty and economic, socioeconomic factors. Here is some of the literature review regarding the global anemia disparity. In 2024, WHO highlights the high anemia rate in South Asia and Sub-Saharan Africa due to poor health and diets. Socioeconomic economic factors in Africa and Asia, like rural population in Malawi and Eastern Africa, face higher anemia risk due to poor health, and while micronutrient deficiencies in Pakistan, Nepal have the same issues. Anemia and socioeconomic equality, this is the major challenge for India. Like in NFHS 5 reports, 57% anemia prevalence among the Indian women with disadvantages group like scheduled caste and scheduled tribe. Nutritional deficiency and socioeconomic barrier, iron, folic acid, B12 deficiency compounded by poverty and healthcare access drives India into the anemia burden. Regional disparity is very much been prevalent in India. Like high anemia rate is seen in Uttar Pradesh, urban centers like Mumbai, influenced by education, diet, fertility factors. Anemia Book Bharat strategy for anemia reduction through supplements and healthcare improvement. It was highlighted in the NFHS 5 data. Now coming to the data and methodology section, I have taken the data from NFHS National Family and Health Survey 1990 to 2021, covering the 7,24,115 women aged 15 to 49 years across the seven regions. And in this method, I have employed the Alcar-Foster methodology for calculating the multidimensional poverty for 27,95,894 individuals for assessing health, education, health, and living standard. After that, I have employed a statistical method of logistic regression and the descriptive analysis. For multidimensional poverty, I have taken the global indicators like health, education, and living standard. In this, the nutrition, child mortality; for education, years of schooling, school attendance, and for living standard, I have like cooking fuel, sanitation, drinking water, electricity, housing, and asset. And accordingly, the weight has been given. 1/6, 1/6 for child and child mortality and nutrition, 1/6, 1/6 for year of schooling and school attendance, and 1/18 for cooking fuel, sanitation, drinking water, electricity, housing, and assets. After that, coming to the methodology section, the head count ratio represent the proportion of a population that multidimensional poor, thus indicating the incidence of poverty, and intensity of poverty is the average proportion of deprivation experienced by the poor, reflecting the depth of poverty. And multidimensional head count is the ratio of multidimensional poor people to the total population. And intensity is the intensity of multidimensional poverty reflects the average deprivation score of multidimensionally poor people. And MPI is calculated after multiplying the intensity with head count with intensity. So, for logistic regression, I have taken the woman having a anemia as a dependent variable, and these are residents in antenatal care visit, dietary pattern, currently pregnant woman, region, wealth, iron intake, caste, currently breastfeeding, religion, presence of water for hand wash, use of soap, menstruation in last 6 weeks, family size, and multidimensional poor as the independent variable. Now coming to the results and findings. The regional variation in anemia is highest in Eastern India, which shows 66.65, while Southern India has the lowest with 54.43. And the but in southern region there is a highest anemia, severe anemia, that is 3.49, and more like different kind of anemia in moderate versus severe, that Central India has the lowest in comparison to the relatively to the higher population is severe anemia is 2.23. Comparable to the anemia rate, northern and western India report similar anemia prevalence, which is around 56 to 58, while the Union Territory region aligns with the national average of 57.05. Now the multidimensional poverty, which has been calculated by the Alkire-Foster methodology, these are the division of the region, like northern, northeastern, eastern, central, western, southern, and Union Territory. In eastern region, the highest poverty headcount ratio is 25.8, followed by the central 22, and northeastern 20.6, and southern is the showing the lowest 5.6, whereas intensity of poverty is high in the region in eastern region, which is 42.6, whereas lowest in the southern region 37.5. And overall MPI is also highest in the eastern region, followed by central, northeastern, and the lowest is in southern and the Union Territory. Now coming to the deprivation, indicator deprivation of indicator region-wise analysis, like in education and nutrition deprivation, eastern region having the highest, whereas the northern region and Union Territory having the lowest. Child mortality and sanitation, which is the central region having the highest, whereas the lowest in the southern and Union Territory. And infrastructure and economic disparities, the northeastern and eastern region has been the highest and the lower in the south and Union Territory. This is the socio-economic profile of the woman of reproductive age having anemia, like the one who is a multidimensional poor having like 67.87%, those who are not having a multidimensional poor but having anemia, and those who are having a multidimensional poor having anemia is 68.78%. The according to type of resident, it is 67.40 in rural area, and urban area it is 64.25 in eastern region. The eastern region is showing the highest prevalence of anemia in all categories, like in a multidimensional poor, type of residence, wealth and presence of water for hand wash, soap used, dietary habits, like iron intake. Though the iron intake of
Pushpendra,
iron during pregnancy don't affect much on the anemia. Same
Pushpendra,
as, yes, sir.
can you come to close to conclusion, please? We are
Okay,
running
sir.
over time. No. You still have some few minutes, but please run fast.
Okay. So I am coming to the direct to the logistic regression result. The logistic regression result is socioeconomic regional factor. Women from multidimensional poor household and rural area faces higher anemia risk. Eastern region women are significantly more likely to have anemia, while those in the southern regions are less likely. Wealth and hygiene impact, anemia risk decreases with increase in wealth, but and improved hygienic practice such as access to water and soap for hand washing. Diet and reproductive health and demographic, vegetarian women and those with a larger family are more likely to experience anemia. The likelihood is lower among currently pregnant women, but higher among the breastfeeding, with mixed finding related to ANC visit and hemoglobin, which is the mensuration during the last six weeks. Now coming to the conclusion, the regional disparity prevalence varies significantly as the result is showing. With the eastern region having the highest and southern is the lowest. Socioeconomic impact, women with multidimensional poor having the similar higher uh, prevalence of anemia as compared to the lower wealthier women. And hygiene and sanitation, access to water and hand washing is reduced the anemia rate. Dietary practice, vegetarian women have higher anemia, suggesting the need for targeted nutritional intervention to address the iron deficiency. Reproductive health, pregnant women are less likely to have anemia, possibly due to increased healthcare access, while breastfeeding slightly increase anemia risk due to higher nutritional demand. The higher anemia rates among women attending more INC visits might indicate more frequent monitoring of those with health risk. These are few policy recommendations from my sides based on the results, like develop for region specific intervention, develop tailored strategies to address anemia in high prevalence region, focusing improving socioeconomic condition and healthcare access. Nutritional program implement targeted nutritional intervention, particularly for vegetarians, to address iron deficiency, improve overall dietary practice, enhance hygiene, promote access to clean water and soap, improve hygiene practice as a part of anemia prevention effort, support reproductive health, strengthen reproductive health service, and support breastfeeding women to manage anemia risk effectively. Research and data improvement, conduct longitudinal study to better understand causal pathways and assess the effectiveness of intervention, addressing limitation of current cross-sectional data. Thank you. That's all from my side.
Thank you, Pushpendra. Thank you so much for your presentation. Very insightful. Our next presenter is Preeti. She is a research scholar at IIPS Mumbai. Preeti, you here?
Yes, sir. Yes, sir.
Yeah, please go ahead and take over.
Am I audible?
Yes, you are. I think the screen is coming. It's still not yet.
My screen is hello.
Yeah, your screen is not showing up. You might want to stop and try one more time. Stop sharing the screen and just start again. Preeti, you there?
Yes, actually, it's not.
So if you press the same share button, it will stop. Yes, now we can see. Go ahead, please.
Hello, everyone. My name is Preeti, and I am one of the research scholars from International Institute for Population Studies. My research topic is rural-urban disparities in alcohol consumption and its association with the multimorbidity among older adults in India, evidence from DASI. Let's move to introduction. Harmful alcohol use is a significant harmful alcohol use is a significant public health problem globally. Excessive alcohol use has a direct impact on health-related sustainable development goal number 3 through the infectious disease and non-communicable disease and mental health. In 2016, approximately 49% of alcohol attributable disability adjust life years were due to NCD and mental health conditions. In India, the prevalence of alcohol consumption among older adults dealing in multiple health conditions varies between rural and urban area due to difference in social cultural factor The distinct pattern observed underscore the necessity of tailored research and intervention to address the morbid older patient in diverse geographic contexts. In data and methods, data sources, LASI, longitudinal aging study in India, 2017-18, day 1, and respondent are older adults aged 45 and above, diagnosed who are 2 or more chronic conditions, multimorbidity condition, and outcome variable are alcohol consumption among older adults having multimorbidity, or group variable are residents, rural versus urban. And statistical analysis, descriptive statistics, logistic regression estimate, and Ferry decomposition method were used to accomplish the study's objective. For the study, data analysis were done using Stata version 17. For result and finding, alcohol consumption prevalence is 27.29 among multi-morbid older adults in urban area. And 15.5 in rural India. Alcohol consumption is more common among older adults with multiple chronic condition in urban setting compared to rural one. So for the odd ratio explaining the multimorbidity, alcohol consumption among multimorbidity older adults in India, the alcohol consumption and multimorbidity are strongly linked with the alcohol user having significantly higher odds of being multimorbidity. And a female are 1.33 times likely than males to have multimorbidity. And individual who consume alcohol 4.703 times more likely to be multimorbid compared to those who do not consume alcohol. This association is highly significant. And 61 to 69 age group are 1.77 times more likely to be morbidity. And those who are not in urban, those who are in urban, not in urban, are 1.19 more likely to have multimorbidity compared to those who are in urban union. People living in urban area are 1.714 times more likely to have more multimorbidity compared to rural area. And if we see the caste wise, if we see the religion, Muslims are 1.54 times have multimorbidity. If you see the wealth index, the richest group is 3.05 times more likely to have multimorbidity. And those who are not working, 2.085 times more likely to have multimorbidity compared to who are working. And this is the estimate of rural urban decomposition analysis for the contribution of explanatory variable of alcohol consumption among older adults. So this shows the percent contribution in the factor which is most contribute in the rural urban difference. So most important, most effectively, the current working or the working status is 94.58% contribution, and education 20.22% contribution. Means education, caste, employment are the major drivers of rural-urban gap in alcohol consumption. Rural are likely having lower education level, different caste distribution, and higher working working rates among older adults. So this shows that the rural people are working. So that's why this currently working factor is higher in that rural-urban decomposition analysis of percent contribution. So move to discussion. The prevalence of alcohol consumption among older adults, multimorbidity was 11.79 higher in urban area and 27.29 than the rural area. Older adults with multimorbidity belonging to the scheduled caste group were 40% more likely to consume alcohol. Older age, female gender, urban residents, or higher level of certain caste, religions, wealthier individual are those who not working more likely to experience multimorbidity. Or additionally, that fairly decomposition analysis revealed that the education, caste status, and employment status were the factor contributing to the differences in alcohol consumption prevalence among older adults with the multimorbidity between rural and urban areas. So conclusion, we found the significant rural-urban difference in the consumption among older Indian with multimorbidity, and the finding underscore the need of target the address the challenge faced by the older patient in the rural area and urban area, including the lack of social capital, limited resource that enable access to healthcare services. Policymakers and healthcare professional collaboratively design the implement effective strategies, limit the alcohol consumption and overall well-being of urban older adults, particularly those with multiple comorbidities. Thank you.
Thank you, Preeti. Thank you for excellent presentation. And our next speaker is Vandita Ranjan. She is a research scholar at IIPS Mumbai. Vandita?
Yes, sir.
Please go ahead.
Okay. Yes, sir. I'm facing problem to share my screen. Actually, Preeti
Preeti,
already.
I think you need to
Yeah.
stop presenting, Preeti.
Yes, sir.
Okay.
You should be able to share. Okay, it's coming now.
Oh, okay. Oh, sorry,
Nope.
sir. It's stuck. My screen is.
Okay. You need to stop presenting and start
Yeah.
again.
Okay, sir. Yes, sir. I don't know why. Okay. Now it's.
Yep, now we can see your screen. Go ahead, please.
Good evening, everyone. I'm Vandita. Today I'll be presenting on psychological well-being and sorry. Yeah. Okay. Today I'll be presenting on psychological well-being in elderly Indian population, the role of family. This topic is becoming increasingly important given the demographic change in India, and today we will exploring how family affect the mental health of elderly. So let's talk about the rapid demographic shift happening in India. With declining fertility rates and longer life expectancy, Indian elderly population is booming. Urbanization is also contributing to this shift, presenting new challenge for healthcare, social security, and the overall well-being of older people. At the same time, the traditional family landscape is evolving. The concept of collectivism and filial piety, which supported elder care, is given way to nuclear families, migration, and changing social values. As a result, many elderly individuals are left behind, weakening their support network. Additionally, with more uh, women participating in the workforce, the traditional family caregiving model in certain strength. This creates challenge like chronic illness, financial insecurity, and social isolation for older adults. To study this, I have used LASI data, and the respondents are elderly aged 60 and above. Outcome variables are depression and level of life satisfaction, and the explanatory variable is family characteristics, variables related to family characteristics. Statistical analysis, uh, I employed descriptive statistic to assess the characteristics of sample. Next, I performed bivariate and multivariate regression analysis to investigate the relationship between depression, life satisfaction, and the family characteristics. Coming to the result and findings, this graph shows that the smaller households and living alone are strongly associated with higher depression and lower life satisfaction. Smaller living with family, especially with a spouse and children, provides emotional support that lowers depression, but larger households do not necessarily result in higher life satisfaction. Being married or in a union generally protect against both depression and dissatisfaction. And next is the association of depression with family characteristics, and another is the association of life satisfaction with family characteristics. In this, we can see that in term of household size, larger households provide emotional and caregiving support, which lower depression risk, especially in rural areas where multi-generational living is more common. Living arrangement are sorry yeah living arrangement, those who live alone face a much higher risk of depression compared to those living with family member, living with children or brothers or other family members. Marital status also play a critical role. Those not in union, like widowed and separated individuals, are more likely to experience depression. And in case of sex composition of children, having both sons and daughters seems to contribute positively to elderly mental health. Okay, now coming to the discussion. Household size and larger household size provide emotional and caregiving support, and which lowers depression risk, especially in rural areas where multi-generational living is more common. Additionally, living arrangement are key as social isolation leads to higher depression rates. Living with children or others can buffer against these effects. Interestingly, those living with both sons and daughters reports higher life satisfaction. This emphasizes the role of families supporting elderly mental health. Coming to the conclusion, to conclude, this study reveals significant variation in mental health outcomes depending on family structure. While some elderly individuals living alone manage to maintain good mental health, others living with family might still face challenges. It's important to recognize uh, that not all family structures guaranteed well-being, so personalized approaches to mental health care are essential. Policy should focus on strengthening social support, enhancing mental health services, and promoting intergenerational solidarity. Okay, thank you.
Thank you, Vandita. Wow, what an interesting topic. Family structures and intergenerational relationships. Such an important topic. I am glad I had an opportunity to listen to your insights. Thank you so much. And I think we are running over time, but if you guys have any questions, please to share with us. We will connect with the respective speakers and we'll get you answers. And with this, it concludes our day one sessions. And tomorrow morning at the same time, 9 a.m., we'll see you guys again. And on behalf of the organizers and me and myself and Professor Dhananjay Bansal, I would like to thank everyone, specifically the volunteers. And I'm sure you guys are tired as well. And have a good evening and have a good night.
Yeah, I think I must also thank the chairperson, Dr. Shashanka, for conducting the smooth sessions. Thank you so much, sir. And hope we'll see you tomorrow. So I hope that all the persons who joined today, they will also join tomorrow with the same strength. So thank you all. Have a good night. Bye-bye. Take care.
Thank you. Bye.
Thank you, sir.
So, Numair, who is there? Divya, what should I do? Should I close this or what?